Hi, everybody. Welcome to today's webinar on Florida HIE's Encounter Notification Service for Community Health Centers. My name is Pamela King, and I am the Florida HIT Outreach Coordinator here at the Agency for Healthcare Administration. And today I have with me a panelist of super smart people that are going to talk to you a little bit about the Encounter Notification Service and how it can benefit SQHCs here in the state of Florida. And I'm going to let each of them really share with you a little bit about themselves before we get started. So I'm going to start with Aaron Parsons.
Thanks, Pam. Good morning, or I guess good afternoon, everyone, and thanks for joining us. My name is Aaron Parsons. I'm a manager with Audacious Inquiry, which is the vendor and partner with the Florida HIE, or with the agency on the Florida Health Information Exchange. I've been involved in HIE projects in Florida since 2011, and I'm excited to be part of the conversation this afternoon.
Thank you, Aaron. And then we also have Diane Gaddis.
Hey, good afternoon, everyone. Yes, I am a president and CEO for the Center for the Advancement of Health IT. We are a nonprofit consulting and education organization that has been working with federally qualified health centers in Florida and around the country for, the last 18 years. Everything from meaningful use, patient-centered medical homes, security risk assessments, and now, in the last year, with a great big focus on event notification service. So we love working with our health centers to help them grow the adoption of this particular service.
Great. Thank you, Diane. And last but not least, Suzanne Craiolu.
You stole my line. Well, hi, everyone. My name is Suzanne Craiolu, and I'm the ENS Program Coordinator for the Florida HIE. As the Program Coordinator, I assist providers and hospitals in obtaining information on ENS. I help walk them through the onboarding process, and I coordinate funding when it's available.
So as you can see, we have a great panel here today. I'm actually going to just be asking these folks some questions to help us understand a little bit better about the service. And then I would ask each of you, if you have questions about the Encounter Notification Service, please go ahead. In the question box over on it should be on the right-hand side of your screen. You can ask any questions you would like as we're going through the service and talking about the service. So if you have questions of your own, go ahead and type them in for us. We will open up for a chance to ask some questions at the end of the presentation. If you have questions, there is a section under the attendees section that you can actually click on the hand button and it will raise your hand. And so that lets me know that you have a question you would like to ask. And then I can unmute your line and you can ask that question. So without further ado, I'm going to go ahead and get started. And Aaron, I'm going to start with you. And can you tell us exactly what is this ENS, this Encounter Notification Service, and how does it work?
Yeah, absolutely. Can you hear me okay, Pam?
Yes, we can.
Okay, I just dialed in on another line. I was hearing quite a bit of static, so I dialed in again on another line here. So, sure. So what is ENS, which is what we're here to talk about this afternoon? ENS stands for the Encounter Notification Service, and it is a platform that allows the Florida HIE to route notice of patient hospital encounters out to provider organizations that have patient consent. So we currently have 215 hospitals across the state that are connected that together represent, they're about 60 health systems, 215 hospitals. Together they cover about 95% of the acute care hospital beds in the state. And those 215 hospitals are providing real-time notice of inpatient and emergency department encounters to subscribed provider groups. So ENS is a service that is routing encounter data from hospitals out to providers so that the providers can use it to improve care coordination and the services that they provide to their patients.
Well, Thank you. And Suzanne, who is subscribing to this service? How are they?
Well, currently we have 59 subscribers, and out of those we have 24 ACOs, 12 health plans, 3 hospitals, and 25 providers, the majority of which are federally qualified health centers.
Oh, wow. And so there is a great interest by FQHCs in this service, and it seems to be growing. Diane, why are FQHCs interested, community health centers interested in the encounter notification service, and why should they subscribe? Diane, are you there?
Yes, I am so sorry. I had you on mute. In today's healthcare environment, as we all well know, the primary care provider's role continues to expand, and that is no different for federally qualified health centers. And primary care docs want to follow up on care management. So when a patient is discharged from a hospital, it's so very important to follow up and get them re-engaged in care, make sure they understand their discharge and their medications and get them back in so we can reduce readmission rates. And for the most part, a lot of the health plans are subscribing to this data because there's a value to them as well, and they may share this with health centers. But what is so unique about health centers is their mission for the uninsured as well, and nobody's looking out for them. So by health centers subscribing to this data, they can get access to those encounter notifications that no one else is looking for and get those patients back into their setting and help them improve their care.
Thank you, Diane. That's great information. And Aaron, if I remember correctly, I think just following up on that, on what Diane said, it seems like I remember some data from one of our subscribers, maybe an ACO, where receiving the data directly allowed them to receive a little bit more information. Is that accurate?
Oh, absolutely. So we have, as Suzanne mentioned, there are payers, there are ACOs, there are health systems, there are providers, most of which are FQHCs that are subscribed to the service. And we did kind of a survey of some of our ACO participants about the value that they were deriving from the service. And they definitely pointed to that as one of the more important aspects of being connected, was that they were getting better data. So this particular ACO had direct feeds from a number of hospitals, and as an ACO, they were getting claims from Medicare for their shared savings patients, and they also had commercial contracts, so they were getting claims from their commercial partners that they were contracted with, but they were missing, they got the data in the claims, but that wasn't really actionable in terms of being able to follow up with patients after they've been discharged from the hospital and getting them in for follow-up care and for all of the activities that Diane talked about, doing medication reconciliation, making sure they understand their discharge instructions. All that's kind of critical to do in a fairly short window after a hospital encounter. So claims can't be used for that. And the direct feeds that a lot of entities are getting only cover those particular hospitals. So yeah, absolutely. We've had a number of ACOs and other participants point to that this is, comprehensive, almost universal coverage of the acute care space. And so it's getting them data that they didn't previously have access to.
Okay. And so speaking of data, what kind of data do you receive in the alerts?
Right. So the data it's data that's coming for the most part directly from the hospital. So it's information about the patient's hospital encounter. So it's going to include the patient's name, date of birth, gender, identifying information about the patient, so we know who we're talking about, and then information that they provided at intake at the hospital, so their current address, their telephone number, and that's really helpful, the telephone number in particular, because it's a number they provided when they were at the hospital, just very recently. So it's very, very often more accurate than the number that a payer or provider is going to have in their own records. Also included in the encounter notification that's received over the service is information about the hospital encounter itself. So the facility where it occurred, the date and time, whether it was an inpatient or an emergency department encounter. The notification lets you know whether you're being notified of an admit or a discharge, and then information about the encounter. So the patient's primary complaint, their discharge diagnosis, their discharge disposition, so meaning were they sent home or were they discharged to post-acute care, kind of in very broad categories, where they went when they left the hospital, and other relevant information about the encounter. So it's not clinical data. You're not getting a discharge summary. You're not getting a CCD. It's a pretty thin slice of data, but the value is that it's highly actionable. You know that your patient was discharged from the hospital, this morning or just an hour ago. And so that's the real value in it, is that it lets you engage with your patient immediately to assist them after they've been discharged.
Speaking of using the data, I'm going to open this up I'll open it up to all of you, but Erin and Diane, how are subscribers using the data? How are providers using this data that they receive through ENS? Diane, do you want to?
Sure. With many of the health centers, just starting to use this and derive value, one of the things I'm hearing is prioritization. So on the screen right now, you have that example of somebody that was just discharged with acute myocardial infarction. That might be a higher priority for a care manager to reach out to than somebody maybe that was admitted for a tiny virus of some sort. So it allows that care management team to take this data and now prioritize it based on their focus areas and needs of their patient. Whereas without this detail, it would be just, a shot in the dark as to who they need to focus on. So that's what we're starting to see, is trying to take a small focus group and use it in that manner. And it'll be interesting to work with the health centers over the next 6 to 12 months to kind of find out what other things they're doing with it and how it's improving the overall care.
Oh, wow. Well, great. Yeah, that is wonderful. Erin, would you like to add on to that?
No, I think that's exactly it. So it's about the services that can be provided by the FQHC, by the center, and the needs of the patient. And this data is a window into patient acute care encounters and an opportunity to engage directly with those patients. So Diane nailed it.
And what about transition of care management? Is there, I know that a lot of the community health centers see Medicaid, Medicare, as well as uninsured patients, but how can the data be utilized for Medicare patients?
Sorry, go ahead, Diane.
From that.
Well, I was just going to speak more broadly. So one of the things that's good about this data is when there's an admission, the practice, the medical home FQHC can immediately respond and say, hey, that's our patient. We have records you need to know about in this patient's care. So it's not just from the discharge perspective. Once that health center knows a patient of theirs has been admitted, it's definitely beneficial to that patient for everyone to be sharing information at that point. So that helps with transition of care as well as just overall improved communication. Erin, did you have something else?
Oh, I was just going to mention, and that's a really excellent point, that the actionable nature of the data isn't limited to just post-discharge. When you get an admissions notification, that's an opportunity to work with the hospital staff during the admission and during the time that the patient's in the hospital. So that's a really good point. I was going to speak to kind of the post-discharge, the opportunity for providers who see Medicare patients to provide transitional care management services, which require follow-up with the patient within 48 hours of discharge. And that's really very difficult to do unless you have that insight into the encounters in the first place. And then being able to schedule a follow-up within that 7 to 14-day window that's required in order to provide and then bill for TCM services. But for Medicaid providers, that's been pointed to as a pretty good opportunity not only to improve care and services, but also potentially a good opportunity to receive some return on investment for billing for those TCM services.
I just want to make sure I heard correctly. That's for Medicare
Yes.
providers,
Yes.
right? Medicare, okay. Suzanne, let's pull you in here into the mix. So how does the data provided by ENS improve and change the patient experience?
Yeah, that's a great question, Pam. And I think Diane and Aaron kind of touched on it, just talking about, the improved efficiency of transitions of care from ENS. So let me just start with an example. There's a man who was admitted to a hospital with a heart attack. He was prescribed warfarin as a blood thinner, and he was told to take it when he got home. So he was already taking Coumadin, a different blood thinner, which his provider had previously prescribed to him, before the hospital encounter. But what he didn't realize is that he wasn't supposed to take the Coumadin, he was only supposed to take the warfarin, and instead he took both. So he ended up back in the hospital due to the overdose. So given this, ENS could have helped the patient by notifying that patient's care manager right away, enabling them to do an immediate medication reconciliation. And this man would have not overdosed, and he would have avoided going back to the hospital again. So really what ENS does is it helps personalize this patient's experience. So imagine you're the patient and that you've been recently discharged from the hospital following like a serious health issue. You may be confused as to what your next steps are, or perhaps you have other priorities you need to attend to because you've been hospitalized for some time. So in either case, follow-up appointments are not scheduled. ENS steps in by automatically notifying your provider or your case manager that you were recently discharged and enables them to contact you right away, help you schedule your follow-up appointments, and answer any lingering questions that you may have for your treatment.
Right. Those are great points, Suzanne, especially when you've been at the hospital, a lot of times you're overwhelmed, you're getting a whole bunch of instructions going home.
Yeah.
If you have chronic health conditions, it's very valuable. And that patient engagement just kind of solidifies, that, hey, this my primary care providers care for me. This community health center actually cares what happens to me. I think that's a really valid point in helping to improve healthcare as a whole. I'm going to go back to, we're talking about the people part of it, and that's very, very important. But I'm going to go back a little bit, Aaron, to the process piece of it, and talk about kind of, you talked a little bit about how ENS works, but how does the data get from the hospitals, the data sources, to the subscribers? What's that matching process look like, and how do you get your patients into the system so that you can get your patients' data?
Right. So I started off in talking about the service and describing it, and I mentioned the 215 plus data source hospitals, 95% coverage in the acute care space, but I didn't really talk about how that data gets out to in this case, to the health center that's interested in receiving data on their patients. How do we know that that's your patient? And the way that works is that a provider or a health center that was interested in receiving encounter notifications on their patients will provide us with a list of their patients when they're signing up for the service. And that list includes a number of pieces of information about your patients. So their first and last name, their date of birth, gender, address, city, state, and zip, phone number, insurance ID, a number of pieces of demographic information about your patients. And we load that into the master patient index that kind of powers the matching process for ENS. And as the hospital data comes in, we're comparing those same data elements, first and last name, date of birth, gender, the different pieces of the address, the telephone number, insurance ID, social. We're comparing those from the data that we receive from the hospital to the patient panel that's been provided to us by the FQHC or the provider group that wants to receive alerts on their patients. And the MPI is looking at each piece of demographic information. Each one is weighted differently, and depending on, and it looks at each piece and attempts to match them. And if a patient matches across enough categories and the MPI identifies a match with a very high degree of certainty, then that's indicated as a match, and that notification is then routed out to the subscribing organization. So it's a pretty sophisticated matching process that looks at a lot of different pieces of information. It's helpful in that we're not relying on the patient when they go to the hospital to say, who their primary care physician is, or who their payer is, or their ACO, or their FQHC, when in many instances they may not know, or it's an emergency situation and they're not conscious, or they're just not in a state to relay that information when they're receiving care at the hospital. So this helps resolve that because it just relies on demographics and on information that patients can easily provide at intake, or that can be ascertained from their ID. So once we have a match, we route that information out, and there's a lot of different options for how we relay that information. It can be done in real time. It can be batch delivered once or twice a day, depending on how you intend to use the data and your staffing and other factors. But lots of different options in terms of how to receive it. We can send it as raw HL7 as structured data that can be imported into your EHR. So lots of options in terms of how to receive it, but the whole process is driven by that list of patients that the health center would give us when they were signing up for the service.
Okay, and I will apologize to those that are attending. I was trying to pull up the patient panel, but I'm having some technical difficulties on my end getting that open, so I won't be able to show you that. But you can always go to our website, and that is florida-hie.net. And under the Encounter Notification Services section, there are resources, and you can always go in there and look at a sample patient panel to help you in seeing what you would submit in for that matching process. And speaking of information and subscribing, so say I am an FQHC and I'm interested in subscribing to this service. Diane, what can an organization do if they're interested?
Well, there's a couple pathways they can take. One is to go to that website you just mentioned, and that is also in the footer of the presentation on everyone's screen. And I have to say, you guys have done an excellent job of formatting that information, making it very user-friendly. It's a very helpful resource to understand the program and how to go about getting involved. And so that's one avenue, and in that area you will find the subscription agreement. Of course, with anything, there's always the legalese we all must sign, and then there's the onboarding checklist. Those two documents get completed and submitted. And of course, if anybody has any questions, they can always reach out to me, and I will happily walk them through the initial process, answer any questions about some of the semantics with getting involved in subscribing to that data.
Wonderful. And then, so Suzanne, just kind of following up with that, what does the onboarding process entail? What does that look like?
So there's really 4 steps to the onboarding process, and Diane touched on the first 2, which of course is, signing the subscription agreement and completing the onboarding checklist. I'll add one thing to it besides the fact that they're both on our website. The onboarding checklist just establishes like your ENS preferences and your configuration settings. So once you complete those 2, the third step is to set up and test your secure delivery method. So for example, how you will upload your patient panel securely, or how you will receive your ENS alerts securely. An example of that is an SFTP. So once that's set up, the last thing you'll need to do is upload your patient panel to the ENS via that secure delivery method. So once that patient panel is securely uploaded, then you go live with the ENS service. So the time frame, the duration basically of the onboarding process is a minimum of 2 weeks, and that allows the time for configuration, panel processing, and establishing that transport mechanism. And of course, Diane and the Florida HIE staff are here to assist you in every step of the way.
Perfect. So I'm gonna I'm gonna ask Erin this question. Suzanne mentioned the configuration on how to send the patient panel and receive the patient panel, and she mentioned SFTP. Can you tell us what that is, and then are there what other methods are there for sending and receiving information?
Sure. So to send us your panel, there's two options. One is SFTP, and that is it's just a secure website, to put it in layman's terms, that has interface where you would enter in login credentials, a username and password, and then some folders inside of the site where you can post the files. And that can be our SFTP. We can set one up and issue the health center that was interested in subscribing and was sending us their patient panel. We can set up the SFTP and give you credentials. Or if you already have a vendor, you already have this capability internally, we're welcome. We can use yours, and you can just give us credentials to log in. So you would post your file there, and then we would go pick it up. Or we could use direct to send the file. And that is like secure email, to put that in layman's terms. So secure email protocols. Probably most of the health centers have access to direct already. If not, we're partnered with Impriva on direct services through the Florida HIE. And so that's an option as well. So that's how you would send your panel to us. And then for us to start sending you alerts back, and that would be, once we have a clean panel, that would be about 2, maybe 3 weeks later. We can do that through the same method. We could do it SFTP. We could do it via direct, and you could have it set up on your side where your EHR could pick up the files from the SFTP and incorporate it into the record. That's one option that some folks do. Or we could send it, again, SFTP or direct. We could send it as the raw data. We could send it as an Excel spreadsheet if you prefer to work the data that way. Or we do have a third option, which is our prompt user interface, and prompt stands for proactive management of patient transitions. And what that is a site, you'd be issued a username and password where you'd log in, and it gives you access to all this same data, the encounter data on your patients, but it has kind of a friendly, user-friendly interface for interacting with the data. So it's a very, very lightweight care coordination tool that you can use to interact with the data. So those are the options: SFTP, direct, or prompt, and really they're all available. And it doesn't have to be just one. So if you wanted to get real-time delivery via SFTP or batch delivery via SFTP, we could do that. And you wanted a prompt account, we could also issue you that. And there's no difference in price in terms of all these different delivery options, whether you choose one or all three, how frequently you want to receive it. None of that factors into the price. The base price is the base price, regardless of how you get it set up to receive the alert. So a bunch of different options there, and it's always something that you can change. So if you start with SFTP and then later on decide you want to try out prompt, we can set you up with some prompt accounts. You can try it out and decide if you like it. It's all very configurable and changeable, and fairly user-friendly. So those are the options for sending into your panel and then getting the data back.
And you mentioned price. So speaking of price, I'm actually going to ask, I know, Suzanne, that there's some funding opportunities available for FQHC. So can you share with us a little bit about what's available?
Sure. You know, Pam, this is really a great time to onboard to the service because we currently have funding from the Centers of Medicare and Medicaid to cover the cost of a 1-year subscription to ENS with a maximum panel size of 250,000 patients. So the intent of the funding is to allow providers that time to incorporate ENS into their workflow and help them realize the financial and non-financial benefits of the service. So really, I mean, this is like a risk-free trial, basically, for a year for you to realize, you know, the benefits of ENS. Now, I will say that funding is limited, and it is on a first-come, first-served basis. And so to be eligible, you just need to be, your organization needs to be a Medicaid provider. And to receive the funding, the only thing we need to do, or the only thing on your part you need to do, is send us the Medicaid ID and we'll confirm it. And then we will take care of the billing on our end
Okay,
for
so
the full year.
Okay, so where do they start with that?
Oh, to start with it, well, you could get in touch with Diane or you can contact me directly. I mean, there's really no wrong door here. Everyone will direct you to me to make sure that you get that funding.
Okay, and Diana, you talked a little bit. I mean, you and Suzanne both talked about both of you are here, and Erin, all of you are here to assist the health centers that would like to subscribe. I'm going to, because I just have the contact information up for the Florida HIE. So Diana, I know that you are available and you have walked several of the I think all of the FQHCs that are onboarded now. You've really kind of walked them through that process and helped them significantly. So do you want to share some contact information? I don't have it, I won't have it online, but at least we can get that information out to folks.
Sure, happy to. And before I do, though, let me add one clarifying point, kind of a question I get asked in as many words a lot when we talk about this funding that Suzanne highlighted. What's the catch? What strings are attached? And the one thing I want everyone to understand is there is no catch. There are no strings attached. It's a 12-month funding opportunity. If after the first 2 months, for whatever reason, the health center doesn't like it, they don't have to continue. If after the funding runs out after 12 months, there's no contract anywhere that says, okay, we got you now and you're going to have to subscribe for another year. Nothing like that exists. This is all about taking advantage of the opportunity and the value this can bring to the health center and the patients they serve. So I encourage everyone to take advantage. And so with that, anyone having any questions or other concerns, I've been working with health centers now for over 23 years, and I can hopefully help navigate anybody to the answer they need to understand the value and move forward with this. So my contact information is simply Diane, D-I-A-N-E, .gaddis, G-A-D-D-I-S, at advancehealthit.org, and that's advance, A-D-V-A-N-C-E, health, H-E-A-L-T-H, IT.org. And you can also reach me at 727-573-2422, and that's extension 307.
You know, I would just add to that, Diane, getting providers connected electronically is in the public interest. So there really isn't a catch in that sense that, our federal government deems that to be something worthy of them helping support that financially.
Absolutely. And the ultimate goal, I think, is, to improve health care, right? Reduce overall costs, improve health care. And we know that can be done only through individual providers. That's where that basic care comes from, and wellness and follow-up and coordination of care. So we're not duplicating tests and duplicating efforts, right, or causing harm because we don't know what all patient medications, or the patient doesn't understand the medications that they're prescribed from, not subscribed, but prescribed from different sources. So I think that's really important. And I'm going to, Diane can provide assistance. Suzanne, Erin, our contact information is on the website. You can get to us also through the Florida HIE website. There's a contact us section, or how to get in touch with us, so you can always contact us through that. And I am going to end the presentation portion of this by asking Erin to kind of give us a kind of look into the future. What are we looking at with ENS for the future? What does it look like in Florida?
Yeah, thank you. That's an exciting question. I want to just take a quick second to echo what Suzanne said about there being no wrong door. I like that phrasing. And the folks on the phone, so Pam, Suzanne, myself, Diane, you will very likely interact with one of us in process of onboarding. So we're not going to hand you off to someone else. Like, we're the folks you'll be dealing with. And we're all very accessible and easy to get in touch with. So certainly reach out to us. But yeah, so the future of ENS in Florida, I'm going to talk short term and medium term. Short term, we have two really great upgrades that are coming. They're both slated for release next month. One is to an upgrade to the ENS service itself. And we're going to be upgrading to a new version of ENS that includes a bunch of different features that will be pretty exciting to our participants. In addition to just general performance improvement and kind of background stuff that makes things work better, there's some front-end stuff that will make the user experience better. A big one being that the new ENS is going to have condition-specific alerting. So for a health system, for example, that wanted to subscribe and route the alerts out to ambulatory practices in their community, they could limit the alerts. They could set it up so that alerts would be triggered on specific conditions out to specific practices. So if they wanted to do alerting to a cardiology practice that was affiliated with the hospital, they could limit the notifications that would be triggered to those diagnosis codes that were related to cardiovascular diagnoses. So that would allow them to just send it out, cardiac specific alerts to the affiliated cardiology practice. There's a lot of different applications for this particular functionality where you can take any part of the notification and or any part of the data and trigger notifications on it. So if you just wanted to do alerts on specific age range or specific conditions or specific facilities, that's all within the realm of possibility. There's also an opportunity to trigger notifications based on the number of encounters that someone had. So if a subscriber wanted to just get alerts on their high utilizers and that was it, on someone who's had 3 or more encounters within the last 6 months, that's something that the new platform would be capable of doing. It also has the ability to trigger calls to external sources of data. And we're still in the process of negotiating and looking at what some of those external sources of data would be. But just as an example, in other states, there is the opportunity to receive PDMP data through ENS. And I don't know that that's going to unfold exactly that way here in Florida, so no promises around that particular data source, but just as a general function, there'll be the ability to go in and pull not just encounter data, but data from other sources as well, perhaps CCDs from a hospital that we're connected to. So some new exciting features in the newest version of ENS. We're also rolling out a new version of Prompt next month that's going to include a census view, so that when you log in, not only would you have your notifications and you'd be able to see who had had encounters recently, but there'll be a page where you can have a census view and you can see everyone who's in the hospital right now. So it's like a hospital, master hospital census. And there'll also be a notes entry functionality, so that if you go in and you're following up with some of the folks based on the notifications that you've received, you can enter notes on the notifications that other members of your team, when they log into Prompt, would also be able to see, and they themselves could enter notes as well. So some exciting updates to both ENS and Prompt that are happening in the very short term. Those are both slated for next month. Over the medium term, for the future of ENS, we're looking at adding more data sources. In particular, we know that this being Florida, that there is a lot of interest in post-acute and in skilled nursing facility data. So we're talking with a lot of different folks about that right now, to engage skilled nursing facilities to connect, to also contribute their encounter data to the platform. And then another kind of medium-term enhancement that we're looking at is the opportunity for retaining the hospital encounter data that we receive. Right now we receive it and we route it out to the connected health center or the ACO or whoever has that patient on their panel, and we purge it from our system. And if we were able to hold on to it, there's a wealth of things that we could do, so that, let's say we route you an alert, you would not only get the alert for the encounter that just happened today, but we could also, with that alert, tell you about prior encounters as well. We could do risk scores. There's a lot of exciting analytical things we could do. if we were holding on to that data. Right now, we're purging it all. And so over the medium to long term, we'd like to work with the relevant stakeholders to get permission to hold that data so that we can offer more value. But still a tremendous value in the service as it exists today, but we have some short and medium term enhancements that we're pretty excited about.
Wow, Aaron, there's a lot to look forward to in the future. So I do have a question, it looks like, or we do have a question from Kathleen. You guys have a question from, it looks like Kathleen. Kathleen, I'm going to unmute you. Can you, would you like to try and speak and ask your question? Kathleen? You may be muted on your end. I have that your microphone is open. Okay, we are not able to hear you. So if you want to type in your question, I'm not sure what's going on and why we can't hear you, but if you want to type in your question, we'll certainly try to answer it for you, or you can email us at the email address on the screen. Unless you want to try one more time. Okay. I do want to open it up for questions from others. Is there anybody that has questions for any of our panelists today? Wait and see if we can get this question written in. And answer it. While we are waiting for that, do any of our panelists have anything else they would like to add or information they'd like to add?
Hey, Pam, it's Diane. I'm going to go ahead and type my email address and phone number into the chat box and send it out to everyone, so in case they didn't get that, they have a way to reach me.
Wonderful. That's a great idea. Thank you, Diane. And just one of the questions, and Diane talked about this a little bit as far as the cost and the funding. One of the questions we get, so after that first year, what are the costs? And for providers, it is, I'm looking at, gonna ask Aaron and Suzanne to correct me if I'm wrong, but I believe it's 30 cents per patient with a minimum of $2,000 for a whole year, right? So that would be $500 a quarter, $500 a quarter. And I know from other users I've heard that they've been able to, the information that they're provided, they're able to either reduce costs or get a additional income from transition of care management that actually covers those costs and sometimes exceed the cost that they're paying for the service. So just wanted to make you aware of the cost after that first year. One of the reasons we wanted a year's worth of service that is covered is to provide you with an opportunity to find out how can we best utilize this information, how can we get it into our workflow, how can the practitioners working in our office use this information, how can our care managers use this information to improve the processes, improve the healthcare and the care coordination that we are using. So just wanted to share that information with you as well, okay? And Diane has put her information into the chat section.
Just so you know, Pam, I don't think everyone can see that. One of you might need to copy and paste that and direct it to all participants.
Okay. Let me, and then I think we have that question. Let me see.
Oh, she said thank you.
Okay. The question is, how accurate is the reporting are we dependent on the hospitals to send all the admission and discharge information? Also, will you send out the presentation? I can answer the last one. We'll answer that one first. So yes, there will be a recording of this presentation, and so we will send you a link to the recording. And then I am going to ask Aaron if he could answer the other two questions. So the first one was, how accurate is the reporting? And then the second is, are we dependent on hospitals to send all the admission and discharge information?
Sure. So we are receiving from the connected hospitals, we're receiving pretty much all of their inpatient and emergency department encounter information. So they're sending it to us as ADT messages, which stands for Admit, Discharge, Transfer. And these are the notifications that track, or the messages that track patient movement through the health system. So these exist independent of their participation in ENS. And what they did when they connected was they agreed to send us copies of all of these. And there are some limitations. We don't get observation, we don't get outpatient, so it's just inpatient and emergency. We don't get Part 2 data, so data that comes from a dedicated substance abuse unit within the facility, that's excluded. But otherwise, our connected hospitals are copying us on all inpatient and emergency department encounters from their internal system. So we're getting, as the vendor and business associate for the service, we're getting all of this data. Restricted self-pay, sorry, is also excluded. But otherwise, we're getting all the inpatient emergency data. So our ability to route it out to you depends on two things. And one is on the sophistication of our matching process, which is state-of-the-art and really cutting edge. We're partnered with really great partners on this. We use IBM technology to power the MPI. And we have some really sharp people that know these tools really well that tune the algorithm to make sure that it is as accurate as it possibly can be. So this really is the space in which we as a company specialize and in which our expertise really resides. So we're really very good at the process of matching, and we have really great tools to do that. So that's one piece of it, is the quality of our tools. Which we have a lot of confidence in, and we're really proud of our ability to deliver on that. The other piece in terms of accuracy of matching is the quality of the data that you give us up front. So I mentioned before that in subscribing and in onboarding, you're going to provide us with a list of your patients, and it should include their first and last name, date of birth, gender, address, city, state, zip, phone, insurance ID, other pieces of demographic information. And the more information that you provide us in that template, there's a standard template you need to use, it's available online. The more complete that is, the better the matching is going to be. So that's the piece that that you as a health center or as a provider really have control over, is giving good quality data up front. And the better quality we get up front, the better the matching will be, and the better we'll be able to route the data out to you. So we get, to give a very short version, we get all the data from the hospitals, and we can get that out to you, assuming you give us a good panel up front. We'll have very high data quality coming out of the service. So it's a really good question.
That was a really good question. Do we have any other questions? Okay, it looks like that it was such a good question that it covered it for everybody, Kathleen. Thank you so much for asking. And I don't see any other hands up or any other questions typed in for us. If you do have any questions that you just didn't want to share with the rest of the group on the webinar today, you can always reach out to us, and we will gladly answer any questions. Or if something just comes to you in the middle of the night, make sure you write it down and contact us, and we'll be glad to answer any of your questions. We appreciate you joining us today for our webinar, and hope you'll join us for future webinars and contact us for any information that you may need about Encounter Notification Service. Everyone have a wonderful day. Thank you all.